based on the Heraclea data that were very impressive in regards to the OBI on-body injector infused device to offer a new sub-Q formulation way to patients, and here with Isatuximab, CD38 antibody, we thought that we needed to now consolidate that data with a much greater population, more patients to consolidate the data, because the results were very, very impressive, and I'll get to that in a minute. So we combined Heraclea, which was a relapse setting Isatuximab sub-Q with Pomadex, to Isalco, that was Isatuximab Carfilzomib-Dex upfront, with a phase 1 study. The 3 studies together offered a great number of patients, more than 6,000 injections, a couple of hundreds, several hundreds patients with myeloma. And so we have been looking at the data we captured with Heraclea. Number one, in terms of safety, how many times the patient had an infusion reaction. Like when you get an antibody, a vaccine, an immunotherapy, anything, for the first time injected in your body, you will have a systemic infusion reaction, immunoallergic reaction. And how many times? Because when it's IV, it's about 25% of the patient. When it's regular manual push, it's between 5 and 10% of the patients. But in Heraclea, it was less than 1% in infusion, less than 1% of the patients. And so with the pool analysis of the database we've had, we confirmed that less than 1% of the infusion, approximately 1% of the patients may have an infusion reaction, most of the time, vast majority of the time, grade 1. So this is not just data, that's a practical importance. Practical importance is that today, when I treat a patient IV, I hospitalize the patient overnight. When I give a sub-Q formulation manual push, I keep the patient hours after the first injection. I believe Isatuximab with the OBI, you don't have to keep the patient in the outpatient clinic for a couple of hours after injection, given that less than 1% of the infusion and less than 1% of the patient will have infusion reaction. Point number one. Point number two, local reaction. With many sub-Q formulation, there is a product mixed to the immunotherapy, and the local reaction can be problematic. I have patients, after the first injection, they have a local reaction. After the second injection, they have the local reaction. And they keep having local reaction that don't entirely recover. It could be painful, could be dangerous for the skin and the subcutaneous tissue of the patients. With the OBI, because of the very tiny gauge of the needle, because Isatuximab doesn't have hyaluronidase combined to it, we confirmed in that study, again, more than 6,000 injections, hundreds of patients, we confirmed that the risk of the local reaction was absolutely minimal. Less than 1% of the infusion, less than 5% of the patients. On top of that, we also need to validate that the device works. And we confirmed that the median time to injection is between 10 to 12 minutes. In a subcutaneous manual push, it's 5, so really makes no difference. We also confirmed that 99% of the time, the injection was completed right within maximum 20 minutes. So the device is very safe. Not only the injection, but the device is safe. So altogether, practically, what does that mean? It means that I believe Isatuximab with the OBI can be given at home. It means that you need to train and educate the patient initially, but thereafter, I'm pretty sure most of my patients can manage that on their own. No nurse, no pharmacist, no team in trouble, because too many patients, too much work, and probably, I hope, a decrease in cost in the end. Because if you can treat patient at home, you save money in transportation. If you can have less nursing, less pharmacist implication, you save money in the nursing and the pharmacist implication. So I even think that in the end, it might be cost effective for the patient, for the countries. So I think it's an amazing innovation, and I'm very happy that I've been part of that innovation. I've been lucky enough to discover that we could be smart enough, the human beings, for inventing such things.